The question about sequencing targeted and immunotherapy treatments is something that we get a lot. And I think that there's not a right or wrong answer in this situation. The things that we consider when we're making decisions about how to sequence is really based on how aggressive the patient's disease is. So if the patient has very rapidly growing disease, rapidly progressing disease, oftentimes we'll choose to start with a targeted therapy treatment because the time to response is quicker. If they have disease that will give us the time for an immune therapy, where classically the response times are between 6 to 12 weeks, then we would prefer to start with an immune therapy. The things that we have to consider with targeted versus immune therapies is that with targeted therapies, they can work very rapidly, but generally they don't work for that long of a period of time. Versus immunotherapies that don't necessarily work as rapidly, but they have the potential to work forever, or what we know of forever, since we do have the 10-year data on IPI, and we know that the patients that were responders for IPI have continued to be responders. So we look at what their disease is doing and what we can do to best serve them at that moment. Sometimes we need to start with the targeted therapy and then make a transition to an immune therapy. I think that it's going to change a little bit with this new approval of combination immunotherapy because the time to response with combination immunotherapy is a bit quicker than with single agent immunotherapy, such as a single agent CTLA-4 or a single agent PD-1. So that again may influence the decisions. So this answer is sort of evolving in the world of melanoma, but for now, that's how we look at this and the things that we consider.